So my name is Annukka Antar, and I'm excited to talk to you today about a cohort study that I've had the privilege of running together with Michael Peluso, who's here in the audience. I have no disclosures. So in the fall of 2020, I had been involved already in a prospective cohort study of long COVID at Johns Hopkins, and AMFAR approached me and Michael as people who are interested in long COVID and interested in HIV to see our interest in running a cohort study to look at long COVID and HIV. And so in our discussions, this was the fundamental research question that we had, which was, are the symptoms and biomarkers of long COVID in people living with HIV different from people who are HIV negative? I'll tell you a little bit about the study design. So what we did was this was a prospective cohort study. We're interested in, again, some of those early time points. We wanted the earliest time point to be about 1 month after infection. So we enrolled adults who had their first SARS-CoV-2 infection within the previous 4 weeks, who were fluent in English or Spanish because we had the resources to do the study in either. And then we were thinking about how difficult it might be to enroll prospectively people living with HIV and also having their first SARS-CoV-2 infection. I had been involved in contributing data from Johns Hopkins to a large registry, and I knew that at least at the time, it was hard to enroll people like this. So we decided to make this a completely remote study. So anyone living in the lower 48 United States could enroll, and we contracted with a mobile phlebotomy company to draw blood, to do vital signs, and to do orthostatic vital signs as well too. And so you'll see on the left there the study design. So we did baseline surveys where they had COVID sometime in the previous 4 weeks, but we were asking them questions about symptoms they had before COVID. So there was some recall surveys there, but then from month 1 through month 12, we administered surveys that we were asking them about right now. And so the surveys were pretty comprehensive. We worked with the patient-led research collaborative, Hannah Davis and others, to design our surveys. They included 49 questions. There were also ability to write in questions. And then we administered a bunch of other validated tools, so the SF36 for quality of life, and then the fatigue severity survey, the insomnia severity index, the BCSS for pulmonary symptoms, pain measures, and PHQ and GAD for anxiety and depression. And we also wanted to really look at brain fog and to kind of define that using neuropsychological testing. So we partnered with Tracy Vandersdaal here who was at Johns Hopkins to design telephone-based neurocognitive surveys that we could administer. And then we were able to collect blood at month 1 and month 4. Alan Landay from Rush was our main partner, main co-investigator along with me and Michael, and his site served as the biorepository for the study. And I'm showing some of the collaborators down there. Leah Rubin helped us with kind of brain health surveys, Pamina with our overall surveys, and Bruno Andrade with our statistical help. And I'm showing you the 4 groups that we enrolled. So we understood that it was important to compare people living with HIV post-COVID with people living with HIV who never had COVID, because we know that people living with HIV who are treated are different immunologically than people without HIV. So we had 4 arms, people with HIV who had recently been infected, people with HIV who had never had COVID to their knowledge, people without HIV also post-COVID and never COVID. And in our studies, we did a couple things. So for everyone who's HIV negative, we ran an HIV test to make sure that they were truly HIV negative. And then for everyone, we did an anti-N antibody, which has its flaws, and I'll talk about that later. But if there was anyone in the never COVID group who turned out to be anti-N positive, then we censored their data. Oh, and I'm showing you there kind of the distribution of participants. So I'm showing you here a table of the characteristics of the participants, and on the left side are people living with HIV, and I'm stratifying them by long COVID, never long COVID, and never COVID. And I'll get into the definitions of long COVID. I have a whole slide on that in a minute. And then on the right side is the HIV negative group with long COVID, and never COVID. So kind of overall things to keep in mind as I talk about the results are the people that we recruited into the HIV arms tended to be older than the people that we recruited into the HIV negative arms. The people in the HIV arms, there was a higher percentage of men, much higher than in the HIV negative arms. And the other kind of main differences was smoking status, which you can see there in the middle. More people with HIV were smokers, and then more people with HIV had hypertension, pulmonary disease, diabetes, and a couple other comorbidities. Now, when it comes to people living with HIV, what were their characteristics? So for the most part, I think 96% of them reported taking ART. Over 80% overall reported undetectable HIV viral loads. We measured CD4 counts in the study, and overall CD4 counts were high with, as you can see there. And in terms of the COVID characteristics of the study, so you can see this study started during the Delta predominant period. So there's about a quarter of our participants overall who were infected during the Delta predominant time, and then the rest enrolled during the Omicron predominant time. The cohort was mostly vaccinated, so that's, again, another difference between kind of cohorts that started enrolling earlier. So over 80% overall had been vaccinated before they got COVID. So in general, the cohort is mostly vaccinated. They mostly had mild acute COVID-19. Less than 5 people were hospitalized in the whole cohort after COVID, mostly with Delta and Omicron. And the people living with HIV were mostly on ART and mostly had undetectable viral levels. So I promised to talk a little bit about our definitions of long COVID. So we had 2 in this study. So one was the prospective research definition. This is the one that we started with. So at a study event that was month 3 or later, and the study ended at month 12, the participant had to report 2 things. One, that they had a symptom of the 49 plus write-ins at some point in the past week. And they also reported that their health was not back to usual, or their health is worse than before COVID. There were 2 separate questions that we had about that. And so if someone met that at one time period at month 3 or later, we said that they had long COVID ever. But then we realized that we might be missing people who might have prolonged recovery but not say to themselves that I have long COVID, or other people who think that they have long COVID, but we caught them in a study window when they weren't having symptoms. So we did a cross-sectional survey at the end of the study. So this was done once, and it was done once between 1 year and 2.5 years post-infection. So that was subject to recall bias. And so we showed a simplified version of the World Health Organization definition of long COVID, essentially that at a time period 3 months or more after infection, you have new and persisting symptoms or sequelae, and they've lasted for 2 or months longer. And we asked, have you had this and when? So I'm showing you here of this number. So on the left, the people with HIV, there were 62 people who we could assign either ever having long COVID or not in the post-COVID arm. And about 17% of them reported long COVID in the cross-sectional study. You can see that in kind of blue and green. And then a much higher percentage met our research definition of it. So in the study, what we did was we combined them. So if you met long COVID either through our research definition or for this through this self-report, then we said that you had long COVID. All right. So we wanted to understand what are the distinguishing features, what are the distinguishing symptoms, and also biomarkers. So I'm going to talk about the symptoms for a little bit. So we worked with our statisticians to ask what baseline characteristics and post-acute symptoms were significantly associated with long COVID versus full recovery. And so we queried basically everything in our cohort. And what I'm showing you here are things that were statistically significant after correction for multiple comparisons. So the more significant ones were having pain, reporting pain or physical dysfunction and fatigue pre-COVID. And in the post-acute features, the most significant things were things like your symptom score, your insomnia severity index, an anxiety score, depression score, an emotional well-being score. And then slightly less significant, but still statistically significant, were other factors, which I'm showing kind of in that bottom row, including age. slightly older age in this cohort was associated with higher risk of having long COVID, and then fewer hours of exercise was associated with higher risk of having long COVID, and as well as the other features that you can see there. So I'm just showing you kind of a snapshot of the 49 symptoms. They're colored by the domains, which you can see on the kind of the bottom right. And this is just to kind of show you that, at 1 month post-COVID and 4 months post-COVID, with people with HIV on the left and HIV negative people on the right, the symptoms that people experience are largely the same between HIV positive and negative, with fatigue being the most common symptom in both groups, and then neurologic symptoms also being common in both groups. So I'm now going to talk about some of the results from the blood studies that we did. So I'm just going to talk briefly about antibodies and then get into other immune markers. So in general, this was a nice study because we collected blood from people with and without HIV at specific times after infection, and we're able to show that there was no difference in post-COVID antibody titers by HIV status. So if you had HIV or not, your antibody levels were about the same post-COVID. We also looked on the bottom row at antibody levels against the 4 circulating human coronaviruses that are not SARS, and also saw no difference there. One thing that we did see, we measured an anti-nucleocapsid antibody using 2 different platforms. And what we saw is that, intriguingly for us, there were many people who had proof of SARS-CoV-2 infection, yet at 1 month their anti-N antibody was negative. We thought this was interesting. And so we kind of wanted to understand the factors behind that. And so we actually found that the time from your last vaccination to getting COVID associated with having a positive anti-N antibody after COVID and its persistence. So basically, if you had had a vaccine very close in time to getting SARS-CoV-2, you were less likely to have a positive anti-N antibody. And we think this might be that if you've had a recent vaccination, then your antibody response might be more spike dominant rather than nucleocapsid, or also you might have less replication of virus overall, and less detectable antibodies. So now circling back to long COVID and antibodies, so we actually didn't see any differences in antibodies, the antibody levels between people who developed long COVID and people who didn't at 1 month or 4 months post-infection, either with spike antibody. We did a couple of these. We did spike, RBD, and then 2 platforms for anti-N antibodies, so we didn't see any differences there. When we selected the biomarkers to test, we wanted to make sure we were selecting ones that were relevant, and so we actually used data from what was the preprint of Akiko Iwasaki's paper, and then work from Australia, and then also work from Link, and then also unpublished work from Johns Hopkins. So we put this together into a panel that would fit all together, and that the study could afford. And so I'm going to show you some of those results. One of the things we also did was we looked at antigenemia. So here, this was an antigenemia looking at the MSD platform. So some of the earlier talks you heard today were antigen detection using the Simoa platform from Quanterix. So this is a different platform. And what we saw is that many people post-COVID, if you look at the N antigen on the left there, many people post-COVID and some people who never had COVID, as far as we believe, did have positive N antigens. But this was not associated with having long COVID versus not having long COVID. And then strikingly, N antigen was less common overall in people living with HIV than people who are HIV negative. And you can see those results there. And in terms of S antigen, there were very few people essentially who we detected any S antigen at all. And again, that was not associated. And then mostly there were people who recovered and not people who went on to have long COVID. So in this study, at least, using the MSD platform, we didn't see that antigenemia was associated with long COVID. And then we interestingly found that N antigen was less common after COVID in people with HIV. So I think that's something interesting that we might want to follow up on. So then we wanted to use a systems immunology approach, and this is where we partnered with Bruno Andrade to look at the biomarkers that we'd chosen and long COVID symptoms. So what I'm showing you here is just the correlations of individual symptoms and their severity with individual biomarkers at month 1, that's on the bottom of the circle, and month 4 at the top of the circle. And so I've pulled out for you on the right analytes that were significant, and this is also corrected for multiple comparisons. And so I'm pulling out the ones that are in both month 1 and month 4, and that correlation direction remains the same. And so the analytes that we came out with were IL-5, IL-8, ADAM-TS13, and MIP-1 beta. And so IL-5, that's very interesting, and I'll have a little bit more to say about that later, but this is also something that has come out in a different cohort study that I have a poster on of completely different people. IL-8 has been identified actually in a couple studies as it being associated with long COVID with varying strength. And ADAM-TS13, which also has been published on, and its association with long COVID, and then MIP-1 beta, which is secreted by monocytes and macrophages, also not a surprise. So then our real question was, do the biomarkers of long COVID differ in people with HIV versus people without HIV? So these last couple of slides that I'm showing you here are addressing that. So here we worked with Bruno Andrade's team on a feature selection analysis from feature selection analysis from a random forest classifier model to try to select the most important features at month 1 and month 4 that would correlate with someone ever having long COVID in our study. And so I'm showing you down here the features that were included in the model. At month 1, MIP-5, so that's another macrophage inflammatory protein. Interestingly, this MIP-5 is a chemotactic protein for monocytes and eosinophils. And also eosinophils showed up at month 1 and month 4 as a negative correlation, and that's actually something that we've also seen in our other cohort. IL-6 showed up at both month 1 and month 4 in HIV-negative people. Again, that's not a surprise. That's been reported on many times, and IL-6 is actually a cytokine that during acute infection is most strongly associated with mortality and severity. The RBC distribution at month 1 was also significant. And then when you go to month 4, this is now where we say someone would actually have long COVID at the time of that study event. Again, eosinophil percent, absolute eosinophil count, IL-6, GFAP, which we talked about a little bit earlier from the other speakers, and then cortisol. And I'm actually going to give a talk about findings in cortisol tomorrow, so I'll have a little bit more to say to that. So here is the feature selection analysis, the same analysis now in people living with HIV. And what's interesting is that if you compare what comes out in this analysis versus the previous slide, they're different. So there's no overlapping top features between people with HIV and without HIV in this study. So the top feature at month 1 was the total cholesterol level. This is something that we chose to study because this seems to also come out in feature selection analyses in MECFS. This is also reported on by Ziad Al-Ali's group as a significant feature of people with a post-COVID condition. So it actually came out pretty strong at month 1 in people living with HIV. And then there's the corpuscular hemoglobin concentration, IL-8, which came out in the individual symptom analysis, but not in the HIV negative analysis that I showed you earlier. And then CCL20, which is important in mucosal immunity, and CXCL9, which is another kind of immune migration factor, as well as interferon lambda as well too, which is an antiviral interferon. So just to summarize our work so far, so people self-report long COVID at similar rates regardless of HIV, but using our definition where we're prospectively asking people about their health, there's a trend towards people with HIV having more long COVID, but it's not statistically significant at the size of our cohort. So pre-COVID pain, physical dysfunction, and fatigue associated with later having long COVID. Post-COVID symptoms in general are similar in people with and without HIV. In our study, at least, S and N antigenemia are not associated with long COVID. And interestingly, the important biomarkers of long COVID in people with HIV seem to be distinct from those in HIV-negative people. But this is confounded by the fact that there are other between-group differences. So, for example, the people with HIV were older, they were more likely to be male, and they're more likely to have comorbidities. So we can't put our finger on and say this is just from HIV. All right, and so I'd like to thank many people, so all the participants who donated their time and effort to the study. Michael Peluso, who helped conceive this study and has been along every step of the way. Alan Landay, who his staff has performed a lot of work processing our samples and keeping them for us. And then Bruno Andrade, Tracy Vanderstal, Leah, people who helped study coordinating the students, and especially AMFAR, who funded this study. So thank you.